Thank you very much. I'm very honored to be here today to present the abstract findings on behalf of all the collaborators. So we have been hearing a lot about aging and people with HIV in the last couple of days. And we are also very concerned with the fourth 95 goal with maintaining quality of life in people with HIV. And with that, it's very important to understand the burden of disability as well as the determinants of disability among people with HIV. As shown in this map here, in the last 2 decades or so, the burden of disability as expressed by disability adjusted life years have been improving in a lot of countries, but seems not so in many Asian countries. And also, as most of us who are clinicians here, very often we are concerned with the physical, very HIV-related health issues that might impact on disability. But as we see in this curve here, disability actually has a very multidimensional perspective. Other than physical domains, factors in mental health, social determinants will also affect disability. Because of this, a few of us coming from different areas in this part of the world, from Chongqing in China, Taipei, Hong Kong, Kuala Lumpur, and Singapore, we met a few years ago, actually in one of these APACC meetings. And we came together and thought, oh, it would be nice to set up a multi-center cohort looking at disability and other age-related issues. Therefore, we planned for a case control multi-center study, and our target is to recruit 1,000 people with HIV aged 35 or above with Asian ethnicity and treated as outpatients in for HIV. And we also plan to recruit 500 age and sex match controls for this study. We collected data, demographics, comorbidities, and other HIV-related variables, and we also measure other parameters, including frailty, mood, cognitive function, etc. And the primary endpoint for the analysis for this abstract is moderate disability as defined by the HUDAS score. So the HUDAS is a 32-item version of a questionnaire looking at the different domains concerning functional ability as shown in this slide here. And on the right lower corner, you will see a classical question asking the patient to rate, the person doing the questionnaire to rate their difficulty in 36 of these items in the last 30 days. And in this abstract, we analyze the prevalence of moderate disability between people with HIV and controls. And we also try to determine the variables that are independently associated with disability among people with HIV as well. So for this abstract, we are presenting the interim analysis for the first 933 participants of this study, which we received all data by the end of last year. So among those, 695 of them were having HIV infection. So among those with HIV infection, the average age was around 53 years old, and 80% of those were male. And they had an average duration of HIV diagnosis for around 9 years. 80% of them had undetectable viral load, and around 52% were taking integrase inhibitor, while 41% of them were taking NRTI-based regimens. And at baseline, since this is a age-sex match cohort, so the age and gender were matched or comparable between those with and without HIV infection. But at baseline, people with HIV were less likely to be married, and they also are more likely to be an avid smoker or have issues with substance use in the past. They do have a fairly similar chance of having comorbidities as well as multimorbidity. However, you can see from the table that people with HIV do have higher prevalence of polypharmacy. We also did assessments as shown in the earlier slide, and people with HIV had higher prevalence of frailty, and they also scored higher on the assessments for mood, like PHQ-9, and also on other aspects of mood like anxiety and stress level as well. The cognitive function assessment scores were similar between the two groups. However, using other structured tools, people with HIV did show to have a lower level of social support and a higher level of loneliness. So for the primary endpoint, as mentioned, we used a HUDA score with a cutoff of 2 or greater to define moderate disability. And in fact, people with HIV and the match controls have similar level of prevalence of disability as defined by this criteria. Around 51% of people with HIV had moderate disability. However, when we look at the HUDA's complex score and compare between the two groups, for those with or without employment, people with HIV did have a higher score on the HUDA's complex score compared to people without HIV infection. And in terms of the various domains included in the HUDA's assessment, again, people with HIV and the negative match controls are fairly similar in terms of the impairments in these domains. People with HIV did have a trend of more impairments in social participation. Then we look at the variables that are associated with moderate disability for the whole cohort. And we noted that people who are frail, higher PHQ-9 score, and higher stress level, poorer performance on the marker assessment, and also a higher loneliness score independently associate with the presence of moderate disability. However, HIV status per se was not an independent variable. Likewise, we looked at the variables associated with HUDA's complex score, and the variables shown here were very similar as with the moderate disability. And then we look at the subgroup with the people with HIV and looked at the variables associated with moderate disability. And similarly, among the people with HIV, frail status, a high PHQ-9 score, higher stress level, higher anxiety, a lower score on marker, and also higher degree of loneliness, all independently associate with the presence of moderate disability. So while performing this multi-center study, it was indeed quite a challenge for us. We started prior to COVID, and then COVID set in, so it was a huge challenge. However, when we get all the work done and finally we could have some results today, we fully understand the importance of understanding the burden of illness, not just on the number of new cases or even deaths or AIDS, but really parameters associating with the quality of life would be very important within the region. And also, as we are doing this multi-center study, we understand the differences as well as the similarities between different countries within the region. And doing these multi-center cohort study would allow us to understand more on these aspects. The importance of recruiting suitable controls is obviously something we have to consider. In this particular cohort, we try to recruit controls that share similarities with our people with HIV, just that they don't have HIV infection. So we do recruit not only healthy cohorts of people in the population, but also people with other comorbidities, and also people like PrEP users who do share a lot of similarities with our patients. And in this interim analysis, we did not find an increased risk of disability among our people with HIV. However, we also look forward to our final analysis as well. And we will also highlight the importance of follow-up studies, longitudinal studies, to look at the trajectory of disability burden among people with HIV in this region. And more importantly, as have shown, the determinants of disability was less related to HIV per se or even its treatment, but rather these variables that we sometimes are not very routinely collected in our clinic or addressed with our patients, things like frailty, depression, loneliness, etc. These are the most important variables that determine the presence of disability. So with this, I would like to thank our funders. Without them, this study is not feasible. And on behalf of all the investigators in this study, we would like to thank all our team members for making this possible. Thank you very much.